The following podcast is part of a certified educational activity titled Conversations with Peers About Type 2 Diabetes, Best Practices for Optimizing Treatment Using Weight Management as a Primary Goal. Access the entire activity and complete the post-test at peerview.com/USQ860. Downloadable slides and practice aids are also available.
Hello, this is Dr. John Anderson from the Frisk Clinic at Centennial Medical Center in Nashville, Tennessee. Welcome to this educational activity on initiating conversations about weight management and intensifying therapy for type 2 diabetes. Our goals for today, we want to look at applying guidelines that prioritize weight loss as a treatment target in persons with type 2 diabetes. Overcome therapeutic inertia to intensify therapy timely and appropriately when glycemic and weight goals are unmet. And then refine your shared decision-making skills to develop individualized management plans to address glycemia and weight. And we know that obesity, hypertension, dyslipidemia, and type 2 diabetes, these metabolic diseases are interrelated. And healthy adipose tissue in the presence of high-fat diets, low physical activity, causes adipocyte hypertrophy and hyperplasia, leading to autonomic overactivity, lipid spillover, hypoxia, and overall inflammation. And when you have this kind of adipokine dysregulation, you have increased vascular tone and arterial stiffness. You have increases of the renin-angiotensin-aldosterone system, increased liver inflammation, all of which lead to hypertension. And with a decreased metabolic rate, with decreased insulin activity and sensitivity, decreased muscle perfusion, it leads to type 2 diabetes. And what we know that these processes and this regulation is really not under voluntary control. The ADA standards of care all now address this holistic, person-centered approach to type 2 diabetes management. And at the middle, the goals of care are to prevent complications and to optimize the quality of life. And we have much more information that we need to consider when that patient's sitting with us in the exam room now. We want to talk about glycemic management, and I'll speak in just a moment about clinical inertia. We want to get our patients with the most appropriate medications as quickly as possible to get them to their glycemic goal. And then we want to address weight as well, because we know that's a driver of inflammation and a driver of dysglycemia. So we want to try to achieve weight management goals. And quite honestly, the American Diabetes Association and EASD state there's no reason not to consider initial therapies now for type 2 diabetes that address both. And then there's this whole cardiovascular and chronic kidney disease issue that we need to be addressing regardless of the glycemic control of the person with type 2 diabetes. If they have ASCVD, we need to be using a GLP-1 receptor agonist that's appropriate for that. If not, maybe an SGLT2 inhibitor, maybe a GLP-1 receptor agonist and an SGLT2 inhibitor together. If we're looking at people with heart failure, particularly with reduced ejection fraction heart failure, we're talking about using an SGLT2 inhibitor. And in CKD, we know that SGLT2 inhibitors help to slow that decline of kidney function. But we now have information that GLP-1 receptor agonists can do the same thing. And while we're doing all of this, we want to try to get their blood pressure down, get their lipids to go, get their weight down, try to keep them from not smoking, all the things we've been doing for so many years. And we want to prioritize glucose-lowering therapies to meet individualized goals. So if we want to reduce cardiovascular risk on the left there, we want to use GLP-1 receptor agonists with proven cardiovascular disease benefit. That is dulaglutide, liraglutide, and injectable semaglutide. Alternative treatment strategies, as I mentioned, maybe an SGLT2 inhibitor with proven CVD benefit, or GLP-1 receptor agonist and SGLT2 inhibitor together, and maybe even throw in thiazolidinedione or pioglitazone, which has some evidence for cardiovascular risk reduction. And if we want to reduce A1C, then the approaches with metformin or combination that help achieve that at a very high level are the GLP-1 receptor agonists, tirzepatide, semaglutide injectable, dulaglutide, and oral semaglutide, and then maybe a little less so GLP-1 receptor agonists, metformin, SGLT2 inhibitors, and of course intermediate weight reduction and A1C reduction is DPP-4 inhibitors. DPP-4 inhibitors are roughly weight neutral. So if we're going to look at reducing weight, semaglutide injectable and tirzepatide and injectable are both at the highest end of that. Others, such as dulaglutide and liraglutide, can achieve the same thing. And then we have intermediate GLP-1 receptor agonists that can do this as well. DPP-4 inhibitors and metformin tend to be neutral in terms of weight reduction. This is a study that was published in Diabetes Care not long ago, looking at a cohort of individuals newly diagnosed with type 2 diabetes for whom there was at least a 10-year follow-up. And this was actually a 13-year observation period on average. And what you can see on the y-axis is early exposure. And then you can look at the hazard ratios for both microvascular, macrovascular disease, as well as for mortality. And what we see is that at each level of exposure, 0 to 1 years, 1 to 2 years, having a lower A1C, as we expect, reduces microvascular and macrovascular risk, and it reduces mortality. The further you get of years of exposure of not being under control, you can see that even if you get aggressive and get A1Cs down, you lose the opportunity to have risk reduction by the therapeutic inertia. So again, we need to see our patients with type 2 diabetes at goals for dysglycemia as quickly as we can get them there and keep them there for as long as we can. This is another cohort looking at lifetime risks for cardiovascular disease in men and women in all BMI groups. And you can see in this middle-aged group of individuals with cardiovascular disease, morbidity and mortality on the y-axis, middle-aged men and middle-aged women were much worse off if they were severely obese or obese versus healthy weight individuals. It seems to be a little more prominent for the males versus the females, but still holds up. And we see that underweight actually reduces your risk for cardiovascular disease. But what we also know is being underweight is a all-cause mortality risk. So again, we want to try to keep our patients at a healthy weight for as long as possible. Again, looking at NHANES data from 2013 to 2016, we look at patients total in purple, patients who did not have cardiovascular disease in blue, patients who have had cardiovascular disease in the red. And we see that A1C goals of less than 7% without cardiovascular disease or less than 8% with cardiovascular disease. We can see that more patients got to go with their A1C who had established cardiovascular disease, perhaps because it's a little bit less of a stringent criteria. We see there's not a lot of difference in blood pressure, perhaps favoring the person who's had cardiovascular disease. And not unexpectedly, we see that patients who have had cardiovascular disease are by far more likely to have an aggressive LDL goal because that is one of the key components of secondary prevention. As far as smoking status and BMI, there's really not a whole lot of difference, whether it's less than 30 kilograms per meter squared or less than 25 kilograms per meter squared. But what's interesting, and you can see it there in the top right, just 9.6% of those without cardiovascular disease and 2.7% of those with cardiovascular disease had that optimal A1C, blood pressure, LDL cholesterol goals, were non-smokers, and had a BMI less than 30. So, how do we address therapeutic inertia in our patients? What do we know from a clinical and a practice level intervention? Well, while it's sometimes hard to do in primary care, maybe you just schedule diabetes-only visits where that's the sole focus of what you're going to talk about that day. Ask your patients to be prepared for the visit. Ask them to bring their glucose logs, their meter, their CGM if they have it, and aim to adjust therapy anytime you're not at goal. And then consider making changes between A1C tests based on monitoring. So if you have an A1C that's not at goal, have your patient interact with you before that next 3 or 4 month appointment. And check for barriers. Is there depression? Is there diabetes distress? Is there low health literacy? Is there something we need to know about that patient that we don't? And then how far they are away from goal and whatever new therapy you started. Not everybody needs to be fit into a 3 to 4 month plan. If they're really well-controlled, stable diabetes, maybe every 3 to 6 months. But if you're really working, you may want to see those patients back every 6 to 8 weeks or every 2 to 3 months until you get them to goal. And then for each patient, develop a standardized A1C target. We know that targets should be a little more lenient for patients with a lot of comorbidities as well as elderly patients, but take into account what the patient wants to do. Review and update this regularly and refer all patients for diabetes self-management education, either when diagnosed or when you're making a change in therapy. We all know our patients want to achieve weight loss, but we have to be realistic about setting goals for them. We can't walk into a room and say, well, we need you to lose 40 pounds or 15 to 20% of your body weight. Let's start with what we think they can achieve. And this doesn't have to be a race. We can do this over time. We know that 5% weight reduction improves health. We know that a weight loss of 10% helps reverse some of these disease processes. But really, if you want to reduce cardiovascular events and you want to reduce complications, you really are talking about approaching almost a 15% weight reduction. And this just This is a meta-analysis of about 40 trials looking at the hierarchy of treatment options, looking at changes in A1C, change in body weight, hypoglycemia defined as less than 70 milligrams per deciliter. And what you can see at the very top in terms of change in A1C, tirzepatide leads the list along with basal insulin and sulfonylureas. And then you can see a fixed ratio combination there, basal bolus insulin, on down the line. If you look at body weight changes, again, tirzepatide is at the top. SGLT2 inhibitor and GLP-1 receptor agonist combinations are also at the top, as are the GLP-1 receptor agonists. If you look at hypoglycemia, clearly the ones that don't do that are what we know, is the GLP-1 receptor agonist, the dual agonists, the SGLT2 inhibitors, and you can see on that graph there. But of the 40 trials, the hierarchy of treatment option recommendations is tirzepatide first, then a GLP-1 receptor agonist and basal insulin fixed ratio combination, or a GLP-1 receptor agonist and an SGLT2 inhibitor. Looking at weight reduction on the y-axis and A1C reductions, we can see in the top left where you lose anywhere between 0 to minus 5 kilograms and an A1C reduction minus 0.4 to minus 1.0. Some of the older GLP-1 receptor agonists, lixisenatide and exenatide, plus oral semaglutide. And then you can see that A1C reductions at that same weight reduction, dulaglutide, once a week exenatide, liraglutide, lixisenatide at the higher dose, oral semaglutide as well. And then if you look at A1C reductions of 1.5 to 2%, dulaglutide and liraglutide at the highest dose are on there, but again, still with 0 to minus 5 kilogram reductions. But as you start to get to minus 5 to minus 10 kilogram reductions, it's really the doses of semaglutide you see there, 1, 2 milligram and 2.4 milligram. And then you can see A1C reductions as high as 2.0 to minus 2.5 with semaglutide once weekly at 2 milligrams. But to really achieve the weight reduction of minus 10 kilograms to minus 15 kilograms, as well as A1C reductions of 2 to 2.5%, really it's the higher doses of tirzepatide that allow you to achieve that in the bottom right. So motivating patients with individualized management and shared decision-making. And I'm going to turn this over to my good friend, Javier Morales.
Hey, Mr. Kowalski, it's nice to see you again, and I apologize for signing on a little bit late. I was a little delayed in the office, so thank you for...
Hey, Doc, not a problem, Doc. I appreciate you taking the time.
So what's going on today? How can I help you?
So a couple of days ago at work, I was pulling some cable, and I was up in some spaces that were a little weird. So I was twisting in strange ways while I was pulling, and I did something to my lower back. So it's all sort of locked up.
What have you tried to do to make it feel better? Have you tried anything?
I've done some heat and some ice. I did some of the stretches that tried to work it out, but it's still pretty locked up.
Okay. And there's no urinary issues or no problems going to the bathroom, right?
No, that's all good.
And is the pain going all the way down the leg or just localized to the lower back?
No, it's just in the lower back. Yeah, no, I've got my legs are fine. Like I'm not weak in one leg versus the other or any of that.
Okay, seems to be a pretty easy fix. You can use an anti-inflammatory over the counter. What I'll do is I'll call in a muscle relaxer to take at night, only for a limited time, maybe for about 4 days or so, just to loosen things up in the lower back and make you feel a little bit better. But I am going to recommend physical therapy and stretching to help out with your lower back. Okay.
Sounds good, Doc. Yeah.
Now, I'm looking here at your medical record, and I see that there is a trend in terms of your weight. Your weight has been going up a little bit, and your blood sugar control has also been worsening. You have a couple of moments. Can we talk about? Is it okay for us to talk about your weight?
Sure. Yeah. I mean, I don't know that it's a problem, but go ahead.
Yeah. Well. One thing that we do know is that we do have what's called anthropometric data, which kind of defines what our weight should be based on our height. And it seems that your body mass index, you've heard that term before, body mass index, is at a value of 32, which puts you in the obese range. Right. And we do know that weight oftentimes plays into a lot of different physical complaints that we may have, and even physiologic process in our body. We do know that excess weight can lead to blood pressure elevation, can lead to worsening control, but can also lead to musculoskeletal complaints such as lower back pain, etc. And even your sleep architecture can be affected.
Yeah, but my numbers are good, and I mean, like the last time, my numbers are still good, and really, I think if I wasn't twisting and pulling, I'd probably have been okay. But
And you're probably right. I think your level of exercise and physical abilities are, without question, pretty well. But nonetheless, your blood sugar control is worsening and your weight is going up. And this could lead to significant issues, particularly with your heart in the future. So I think that I would like to recommend making a medication change for you, swapping out one of your medicines for another one that would help you to lose weight and also help to reduce your risk of having a heart-related issue. How do you feel about that?
sure, I mean, doc, you've been my doc for 8 years, so I trust you. You've never steered me wrong. So
Yeah, that's great. So we have different types of medications that are available in the same class. Some of these are taken once weekly via injection, and the other one is available as a tablet form, but it needs to be taken first thing in the morning on an empty stomach with a half a glass of water and nothing to follow for 30 minutes. So which of these medication types would you prefer? Would you prefer the pill once a day, or would you prefer a once weekly injectable?
I think probably once weekly. It just sounds easier than. I mean, there's a lot of detail on the other one.
Yeah. Any way you can come into the office by next week or so I could teach you on injection?
Uh, I'm pretty booked for probably the next 4 weeks, so I probably can't get physically to your office until maybe 5 weeks from now.
I understand. We're all challenged in terms of our responsibilities. But, these pen delivery devices for these injectables are so easy to use and they're virtually painless. What I'm going to do is I'm going to send in a prescription to your pharmacy for one of these medications. And what we'll do is we'll have a video telephone call next week sometime, and we could go over injection in detail. And we'll go over all the procedures about how to set everything up, and we'll complete our first injection together. How do you feel? How do you think?
Sounds good.
Okay, great. Then I will see you next week.
Okay, thanks, Doc.
Bye-bye. Feel better.
Thanks.
So, as we just saw, Simon is a 47-year-old male with a BMI of 32, an A1C of 6.9%, and a blood pressure that's reasonable at 136/82. He's obese, he has hypertension, type 2 diabetes, and suspected sleep apnea. And you can see his medications there, a combination of metformin, a DPP-4 inhibitor, and an ARB. And for the injury that he's had, we're going to give him an anti-inflammatory medication and a muscle relaxant. He's divorced with 2 adult children. This is a telehealth appointment for lower back pain flare-up, which occurred on the job. He also says his ex-wife used to tell him his snoring was very bad with suspected sleep apnea, and he's had a duration of diabetes for about 5 years. Medical history, gradually increasing weight, dysglycemia, and blood pressure over the last 3 years. And so we start to have a discussion about weight. He knows he eats too much fast food for most meals. He does get exercise on the job. And with a suggestion in the change in type 2 medications, this patient really puts you off and says, I really don't want to bring this up. Maybe we can do this at the next appointment. And we get that a lot of times from patients, and we have to hear what they're saying. What we also know is, as an aside, overweight and obesity increases the risk of back injuries. We've seen this in our patient population. This is evidence from the U.S. Navy and Marines looking at over 400,000 back injuries by BMI categories. And you can see that overweight versus healthy carries an increased risk, but obese versus healthy carries an even bigger risk there in the light blue. So when we communicate with patients, is now a good time to discuss your weight? Can we work on this together? You can ask the patient, questions. If they say yes, well, what concerns you about the weight? What have you had success with before? What would stand in the way of achieving that outcome? What do you think would be a good first step? What impact will the changes make? And then the response from is acknowledging their concerns, trying to link obesity to their comorbidities, provide them with resources, schedule follow-up or referral. If the response is no, okay, I hear you, but let me tell you, your weight is going to impact your diabetes and your high blood pressure, perhaps your sleep apnea. At some point in time in the future, let's schedule a follow-up so we can discuss this. In other words, keep the door open. We do this with other disease states too. Patient might not quit smoking the first time you talk about it, but it's that continued relationship that helps the patient come around many times. And then there's the stigmatization about type 2 diabetes and weight that's entrenched in U.S. healthcare practice. This is just a brief survey of over 200 physicians in 2023, looking at how many physicians, what percentage of them had attitudes where they personally felt the patient was responsible for their disease. That's either type 2 diabetes in the dark blue or obesity in the light blue. And you can see that this is the patient's own fault. They have no willpower. Well, they could lose some weight if they exercise a little bit. So we need to check our attitudes at the door when we walk into the exam room with these patients. And this is just a quick reminder of Life's Essential 8. Healthy living is for everyone. These are the American Heart Association guidelines that talk about eating better, being more active, obviously quitting tobacco, getting healthy sleep, managing your cholesterol and lipids, managing your blood pressure, managing your blood sugar, and managing your weight as well. Everything we just talked about. And we also know that duration of overweight and obesity and degree of activity matters. You can see in the green are the active people, in the maroon are the inactive people. And if you had a healthy weight now and 10 years ago, you can see that your cardiovascular disease risk is low. But even if you have a healthy weight and you're inactive, you have an increased cardiovascular risk. And if we go to the far right, where we look at overweight now and 10 years ago, but you're active versus inactive, you have a higher cardiovascular risk with inactivity. So there you have this negative legacy effect with respect to duration of overweight and physical activity. And we know that overweight and inactivity together lead to the worst outcomes in terms of risk for cardiovascular disease. And if we look at the Look Ahead trial, which was a long-term interventional trial looking at lifestyle intervention in a very aggressive way and overall cardiovascular risk reduction, what we see here in some different categories is if we look at change in A1C, you can see some slight decrease in A1C with weight reduction, but it's really not until you get to that 10 to 15% weight reduction that we see the really dramatic decreases in hemoglobin A1C. We also see slight decreases in systolic blood pressure, but the real decreases don't occur until you get to that 10 to 15% weight reduction, and a little less so for diastolic blood pressure. One of the frustrating things for my patients, if they lose a lot of weight, that doesn't necessarily affect their LDL cholesterol. And you can see in the blue on the right there, that's the case. But what you do see when you get up to those 10 to 15% weight reductions is significant increases in HDL cholesterol. So what advice can we give to our patients about lifestyle modifications? And it means different things to different people in different contexts. The thing is, we do know the Look Ahead study is difficult to replicate in practice. It was a significant time commitment, multidisciplinary counseling, frequent follow-up appointments, everything you would expect from a randomized clinical trial. So we have to meet our patients where they live. Let's find a practical starting point, perhaps walking 175 or more minutes per week. If they're not walking at all, maybe we just start with 45 minutes a week, whatever the patient is willing to do, and then increase incrementally from there. And also, don't forget our care team, our diabetes educators, our clinical nutritionists. And a lot of my patients won't show up for those kinds of referrals. But if you make it important, if you spend some time talking during that office visit about how important that referral is, your patients are much more likely to attend or follow up for that appointment. And then the confusion about dietary advice. This is the American Society of Preventive Cardiology clinical practice statement talking about weight loss and then weight maintenance, how to manage or avoid diabetes, how to manage or avoid dyslipidemia, and how to manage or avoid hypertension. And it's a cyclical effort to reduce cardiovascular risk. We tell them to eat more polyunsaturated fats, dietary omega-3s, dietary fiber, phytonutrients, and eat less saturated fat, trans fats, dietary cholesterol, sodium, and calories, as well as refined carbohydrates. So Simon is now back for follow-up, and he's lost about 5 pounds. His A1C has gone down about 0.1%. His blood pressure is roughly the same. He's still on the same medicines. Remember, he really didn't want to talk about other medication changes to his type 2 diabetes regimen or to talk about weight loss therapies. But at the follow-up, he's pretty disappointed with results from his lifestyle modifications. He's only lost about 5 pounds. So how effective is lifestyle intervention in people with type 2 diabetes? Again, these are lessons from the Look Ahead study. What we see is that initially in the treatment group in the blue versus the control group in the orange, you get an initial mean decrease in A1C, but it tends to regress over time, as does the fact that you get an initial weight loss, but it also tends to regress a little bit over time. So at the weight loss in the intensive lifestyle group, about 68% of them got greater than equal to 5% body weight reduction, and about 38% greater than equal to 10% weight reduction versus what you can see there in the control group. But it attenuates over time. It's difficult for people to lose weight on their own and sustain it. And if we look at in the dotted line, the standard of care diabetes support and education group versus the intensive lifestyle group, we can see that somewhere around 80% of these patients may have gotten 0 to 5% weight loss. We see a little bit more towards 50% got greater than equal to 5% weight loss. In the orange there, you can see weight loss of greater than equal to 10%, maybe 20% some. But in the green, the people who got greater than equal to 15% weight loss, even with all of this intervention, even with the support team and follow-up, was really only maybe 10% or less of the patients. And if we look at cardiovascular risk factors, that is weight, systolic blood pressure, lipids, A1C, we see that greater weight loss, as I said before, those higher numbered weight losses see a greater reduction in A1C and weight and systolic blood pressure and lipids. You can see there in the green, the weight loss is greater than or equal to 15% on each of those graphs, statistically significant improvements in A1C, weight, blood pressure, and lipids. So again, somewhere in that greater than or equal to 15% is where we really see the cardiovascular risk factors changing. And at least in the SUSTAIN trial with injectable semaglutide, what we see is that reaching the ABC targets is associated with the higher doses. So if we look at semaglutide 0.5 in the blue and semaglutide 1 milligram in the orange, you can see that the higher doses achieve a better A1C reduction, better systolic blood pressure, better non-HDL cholesterol, and better metabolic composite. And semaglutide, as we know, reduced the risk of 3-point MACE by 26% in SUSTAIN 6 and 21% in PIONEER 6. And the reductions are similar regardless of the baseline A1C and varying cardiovascular risk. We are also learning more about GLP-1 and GIP GLP-1 based therapies on kidney function. We know in the FLOW trial that semaglutide slowed the rate of decline in eGFR in the FLOW trial, and you can see there the separation of the curves. And you can also see that tirzepatide slowed the eGFR decline rate when assessed by both creatinine as well as cystatin C, both on the left there and the right. And we know that a meta-analysis of randomized controlled trials showed that GLP-1 receptor agonists lead to a large reduction in risk of albuminuria and composite renal endpoints, excluding albuminuria. So a doubling of serum creatinine, GFR reduction of 30%, end-stage renal disease, or renal death. And in the FLOW trial, semaglutide reduced the risk of kidney disease events and cardiovascular death in people with diabetes and CKD. And it was the first RCT of a GLP-1 receptor agonist with a primary kidney endpoint. So it was over 3,500 patients with type 2 diabetes and CKD. The intervention was semaglutide 1 milligram versus placebo, and the primary outcome was that composite endpoint for CV and kidney morbidity and mortality. And we can see there a 24% reduction in first major kidney disease event, and then death from cardiovascular disease, you can see a 29% reduction. And so the risk of a primary outcome event was 24% lower in the semaglutide group versus placebo group. And the results were similar for a composite of the kidney-specific components of the primary outcome. And what we also saw is that serious adverse events were also lower for semaglutide versus placebo. One of the things that we have seen so much lately, whether it's formulary changes, whether it's supply chain issues of the last 2.5 years, sometimes we need to switch patients from one agent to another or restart therapy after an interruption. Sometimes it happens because of intolerance to the medication. But we want to try to get these patients successful on their medicine. So I'm a big fan of getting them back to a lower dose and doing a slower up titration to avoid adverse events when we're switching from one to another. I mean, type 2 diabetes is a marathon. It's not a sprint. So if it takes us an extra 6 to 8 weeks to up titrate, that's still going to be helpful if we avoid adverse events. And so again, each agent has a recommended starting dose and a recommended dose titration, and we need to talk to our patients about that if we're switching between medications. And then the safety considerations for approved injectable GLP-1 receptor agonists, as well as the dual combination GIP and GLP-1 receptor agonists for type 2 diabetes, are really well known. The number one side effect potential is that of GI side effects, nausea, constipation, vomiting, diarrhea. And we can talk to our patients about that. Usually it's transient. We can get most of them about it. With exenatide extended release, you can have these injection site nodules, which is part of the way it works. We also know that in patients who get volume contraction, particularly if they have chronic kidney disease, we can have acute worsening of kidney failure, even to the point of dialysis. So we ask our patients to be in touch with us if they have prolonged vomiting and inability to tolerate PO intake. We know that there's been one study where rapid reduction of glucose was associated with a transient worsening of retinopathy. So we keep those considerations in mind. And then, of course, There's pancreatitis, probably an association, not a cause and effect, but certainly if somebody gets pancreatitis on one of these agents, you just stop it and treat them. There have been rare reports of anaphylaxis and angioedema, again, very rare, but if that happens, you want to stop the medication and treat them. But all of these have a boxed warning associated with thyroid C-cell tumors in rodents, and so they're contraindicated in people with a personal or family history of medullary thyroid carcinoma or in people who have MEN2. So coming back to Simon, he's now wanting to think about therapies that might change the way he thinks about his disease. It might help him lose weight. And so we talk about tirzepatide, obviously starting at the lower dose and titrating, or semaglutide, starting at the lower dose and titrating. And then what patient characteristics would change your treatment recommendation? Well, which one's covered on formulary? Which one's available and affordable? What's he willing to do? Is he willing to use a pen needle? Does he want a hidden needle? Those are the kind of things we discuss with him. And then using the 3 E's to manage GI side effects in patients using either the dual agonist or the single GLP-1 receptor agonist, it's the 3 E's: educate and explain. Talk about these GI side effects and their potential so the patient anticipates them. And they're typically mild to transient. Escalate to an appropriate dose. Gradually up titrate. And if you get to a dose where the patient's not tolerating it, you can always drop back down to the lower dose and slower. And then increase your water and fiber intake. I tell patients when we're starting on these drugs, the fatty and the fried foods are going to be the worst. And if it's persistent or severe, certainly you want to think about ruling out other things. But one of the things I tell them is pay attention to satiety cues. If you feel really full, or you're starting to have some of those side effects that you don't know what they are, put the fork down for 10 minutes. Invariably, what happens is patients learn to reduce their portion size with these medications. And then establishing a cycle, using the shared decision-making. We saw with Simon how he really wasn't prepared to do something else. He really wanted to do something on his own, but he was also realistic when he came back and said, I haven't achieved the goals I want. So set achievable and realistic goals. Develop a management plan. And if the goal is met and the plan is working, that'll reduce distress. It will encourage adherence to the plan. New goals are added. Intervention is attempted. And, in clinical trial programs with GIP and GLP-1 receptor agonist combinations, improved glycemic control and reduced weight was associated with adoption of other healthful behaviors. One of my patients that I had on tirzepatide, after 6 months, had lost 83 pounds from over 300. He is a college commentator in hockey. He is now on skates, skating for the first time in 10 years. So what we can see with some of these weight reductions is not only dramatic in terms of the core parameters I've talked about, but an over lifestyle and quality of life satisfaction. So, what do we want to take home from this? Patients have fewer complications with early management of glycemia and weight. We talked about therapeutic inertia. Do not wait. Get them to goal as quickly as you can. And that a nutritious diet and physical activity are foundational to healthy living, but they may have only modest effects on glycemia, weight, and other aspects of diabetes. We know that the dual GIP-GLP-1 receptor agonists and the GLP-1 receptor agonists are the most effective agents for addressing A1C and weight and have favorable effects on other cardiovascular risk factors. So why not consider using them early in the course of therapy? And then finally, type 2 diabetes is a lifelong self-managed disease. And use our experts and use our teams and make sure they're getting their diabetes self-management education. Make sure they're getting support from you, from your office staff, from their families and friends so that we can achieve these goals. That concludes our discussion for today. I hope you found the activity informative and useful to your practice. And I encourage you to participate in related activities in this curriculum, which you can access at PeerView.com. Thank you very much for participating today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. Components of this activity have been developed in partnership with Healthcare Theater from the University of Delaware. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/USQ860.